Good evening and welcome. My name is Amy Knowles, and I am the Assistant Dean for Student Affairs and Admissions at NYU's College of Nursing. And I am thrilled to look out at this wonderful, wonderful audience and to see all of you this evening. Thank you very much for coming out for this wonderful event, the Hillman Alumni Nursing Network and New York University College of Nursing panel presentation on the Institute of Medicine and the Robert Wood Johnson Foundation's Future of Nursing Initiative, Implications for Practice. I bring to you this evening greetings from our Dean, Dr. Terry Fulmer. She's in Washington, D.C. this evening. She sends her regrets that she could not be here. She was so thrilled to hear that this event was taking place and wanted very much to be here. So I send to you greetings on behalf of Dr. Fulmer. I am thrilled to introduce to you this evening your two mistresses of ceremony. And there are two because this is such a spectacular event. So, I first introduce to you Miss Linda DeAndrea. I ask if Linda would kindly stand. She is our director of the Hillman Nursing Network. And I must say, to credit Linda, this is her brainchild, this wonderful, wonderful endeavor. So we thank Linda, and we are so thrilled and honored to be sharing in tonight's activities. Your other mistress of ceremony, an esteemed colleague of mine, the Associate Dean of the undergraduate program at NYU College of Nursing, Dr. Hyla Richardson. And I am grateful to these two wonderful individuals who are now going to lead you through the next hour of wonderful, wonderful, wonderful information. So at this time, I now ask Linda to kindly come to the podium, and she will take us through the next steps of the evening. Thank you, Linda.
Thank you, thank you. Good evening and welcome, Hillman scholars and alumni, to this, our second annual Winter Roundtable. I want to take an opportunity to acknowledge several special people in the audience. Mr. Aaron Michon, you want to stand, Aaron? Where are you? There you are. The Executive Director of the Rita and Alex Hillman Foundation, and also Dory Jaffe. Miss Dory, you know, the Director of Administration for the Rita and Alex Hillman Foundation. And I would like to thank NYU very much for all their cooperation and help in sponsoring this program and for working with us on it. And it's sure to be a wonderful event. As you already know, as Hillmans, we are part of an innovative program. Long before its time, the Rita and Alex Hillman Foundation was a leader in promoting quality health care with scholars programs at the University of Pennsylvania, at New York University, at Beth Israel School of Nursing, Lenox Hill Hospital, and with the formation of the Hillman Alumni Nursing Network. HAN is a place where hundreds of Hillman scholars and alumni find support, mentoring, and opportunities to learn and discuss current trends as well as issues facing nursing and healthcare today. With its commitment to HAN, the foundation has enabled its alumni to be at the cutting edge of nursing. So our topic tonight is very appropriate given the current climate of healthcare, the opportunity for reform, and the vital role that nursing must have in it. At this time, it's my honor to introduce two of the panelists, Dr. Fairman and Dr. Kimberly Glassman. So if you'll allow me, I'll give a brief intro, during which time their faces may turn red with embarrassment, but they're all scholarly, wonderful things. Dr. Julie Fairman is a nurse historian whose work on the history of 20th century healthcare represents a track record of consistent funding, including fellowships from the National Library of Medicine at the National Institute of Health, the National Endowment of Humanities, and Robert Wood Johnson Investigator Program. Her work on the history of critical care earned her awards from the American Association on the History of Nursing, and her most recent book, Making Room in the Clinic, Nurse Practitioners and the Evolution of Modern Healthcare, is in its second printing and recently out in paperback. Dr. Fairman served as the 2009 IOM Scholar in Residence and staffed the Robert Wood Johnson Institute of Medicine Commission on investigating in the future of nursing. Dr. Fairman's a professor of nursing and director of the Barbara Bates Center for the Study of the History of Nursing at the University of Pennsylvania. She's currently working on a history of the intersection of health policy and nurse practitioners in the United States from 1980 to present, and also investigating the influence of the nursing profession on healthcare and looking at the role of the patient as health policy advocate. Dr. Kimberly Glassman. Dr. Kimberly Glassman is the Senior Vice President of Patient Care Services and Chief Nursing Officer at NYU Langone Medical Center. Dr. Glassman joined the medical center in 1978 as a senior staff nurse in critical care and has held many leadership positions in nursing over her career at the medical center. She's conducted research on the patient experience and written chapters for textbooks and peer-reviewed journal articles. She's on the board of several journals, including Applied Nursing Research, Nursing Economics, and Qualitative Health Research. She received her RN diploma from the Massachusetts General Hospital School of Nursing and her BSN from Hunter College. She holds a master's in nursing administration and a doctorate in research and theory development from the NYU College of Nursing. Dr. Glassman is a graduate of the Johnson & Johnson Wharton Fellows Program in Management for Nurse Executives at the University of Pennsylvania. And we're truly honored to have you both on this panel. Thank you very much. At this time, I'd like to call up Dr. Richardson to introduce our other two panelists, but I hope you all enjoy the evening.
Thank you, Linda, and thank you for this great idea for this evening. So good evening and welcome to everyone. It's so nice to see such a great room full of Hillman scholars. This is a very exciting time to see both students from University of Pennsylvania and NYU together and learning together about this great study that's going to be really very important in your careers as nurses. So this is an exciting evening. I'd like to also acknowledge Mr. Michon and Ms. Jaffe, and welcome, and so glad to have you with us. And also want to introduce to you the two panelists who are here tonight to speak about the study itself. And I think that one of the things that we need to keep in mind, I think, as students, as faculty, and working with our students, in particular our Hillman scholars, is that we have had the privilege of working with the next generation of leaders. And I think that that is just it's a wonderful opportunity, and we are, I know at NYU, and I'm sure at Penn as well, very grateful to the Hillman Foundation for that opportunity. So we know we're going to need that next generation of leaders as we learn about the Institute of Medicine report, because it's going to require leadership and nursing to get us through this next stage and to meet the recommendations of the report. So we will proceed now with the people who are going to actually tell us what your roles are going to be in the next 25 years of trying to get us on track to follow these recommendations. First is Dr. Gorvich, Dr. Mark Gorvich. He is in internal medicine at the Bellevue Adult Primary Care Clinic. He's board certified in internal medicine. He received his medical degree from Harvard Medical School and did his residency in primary care internal medicine at New York University School of Medicine and Bellevue Hospital Center. He has an MPH in epidemiology from the Columbia Mailman School of Public Health. And his research interests center on health services utilization, medication adherence, clinical epidemiology among drug users in particular, and other underserved populations. He has done research in pharmacologic treatments for opiate dependence and effective strategies for fostering behavior change among patients and clinicians. After an earlier focus on looking at clinical manifestations in response to treatment of syphilis and tuberculosis infection with drug abusers, he has concentrated on the broad theme of how most effectively to meet drug users' diverse and complex needs for medical care. And so in addition, he co-directs the Community Engagement and Population Health Research Corps of the NYU HHC, which is New York City Health and Hospitals Corporation, clinical and translational science. So he is here because he is in the midst of clinical practice and will reflect on how this Institute of Medicine report is viewed by those practitioners, and in this case physicians, who are practicing in, currently practicing in many different areas, but in this case in a major public hospital in the city. Also, it's my pleasure to introduce Dr. Christine Kovner, who is a colleague and a friend, and is a professor at NYU College of Nursing and a senior fellow at the Harvard Institute for Geriatric Nursing, also here at the college. She is an attending nurse at the NYU Langone Medical Center. Dr. Kovner maintains an active and very nationally recognized research program about the nursing workforce. She is the principal investigator of 2 grants from the Robert Wood Johnson Foundation for the first that studied career trajectories of newly licensed registered nurses over their first 10 years of their careers. She also provides research and data consultation to the foundation. She's a co-author of the Financial Management for Nurse Managers and Executives and is a reviewer for many health-related journals. For 9 years, she was a member of the New York State Hospital Review and Planning Council, a very important position for those who know New York State Health Services. And she serves on the steering committee for New York's Nursing Workforce Center. She was on the Advisory Council on Policy for the Honor Society of Nursing Sigma Theta Tau International. She has her baccalaureate degree from Columbia University, her master's from the University of Pennsylvania, so you can claim her, you from Penn, and her PhD from NYU, so we get to claim her also. So she completed a 3-year postdoctoral fellowship funded by the National Center for Health Services Research and Healthcare Technology, a very big deal, and a senior scholar at the Agency for Healthcare Research and Quality for 2 years. And also, Chris, I'm sure she'll speak about this, was a consultant for this report. And so she was someone that the IOM committee went to ask for information and data and get her expertise. So I think now, Amy, we start our presentations? Okay, so Chris, we're turning it over to you.
I need to get my thing up here. How do I do that, Amy? While they're doing that, I will tell you about my involvement in the Institute of Medicine report. The Robert Wood Johnson Foundation hired 4 people who do research in the nursing workforce to serve as consultants for the Institute of Medicine on this report. We were not allowed to go into any of the secret meetings, and you were allowed in the secret meetings, but we were not. And so our job was to try to anticipate what the committee might need, or answer specific questions that they had and try to find the data that they needed. And then we had no idea ever whether they read anything we sent, and we got no feedback at all. And the only thing we knew up until the day the report was released, and believe me, we spent a lot of time on this, was that there were 8 recommendations. Nothing else did we know. But it was fun, and it's actually still going on. The foundation is interested very much in implementing the recommendations, and so the 4 of us are still on the payroll for them to help them do that. Okay, now how do I actually make this go, Amy? Like this? Yes. Amy asked me to give you some background and context for the report, and so I just wanted to give you some sort of basic facts about nursing and numbers. The federal government, through the Health Resources and Services Administration, does a survey of registered nurses every 4 years. The last one was done in 2008. And here's some numbers. You can see that the number of nurses has gone up consistently since they started doing these surveys. And the number of nurses, the top red line is the number of nurses, the line underneath is the number of nurses who are working in nursing. Age distribution, you can see by the yellow is the curve of nurses in various age groups. And one of the frightening things about that graph for me and Hyla and others is that the workforce is aging. And so we rapidly need all of you to get going and taking over some of our leadership jobs in this area because we are all getting older. Distribution of registered nurses according to their initial nursing education. About 35% of nurses have their initial education as a bachelor's degree or higher. Most nurses continue to graduate from associate degree programs. Oops, sorry, pressed the wrong way. But eventually, many of the people who graduate from associate degree programs do get their bachelor's in nursing, and in 2008 at least, about 50% of nurses in the United States had a bachelor's or higher degree. Racial background, the red is the U.S. population represented by the various racial groups, ethnic racial groups, and the white is the percent in nursing. What you can see is that white people are very overrepresented in nursing, and that Latinos and African Americans are underrepresented. That's something that we at NYU recognize and are trying to do something about, and is definitely something that the federal government and the state government are working on. Employment status, about 84% of nurses are working, but of those, about 63% work full-time and 21% work part-time. One of the things we've seen in the work that I'm doing is that over the last 2 or 3 years, what we've seen with the new nurses is many of them have gone from part-time to full-time, we think in response to what's going on in the economy and possibly partners being out of work. How many nurses are we going to need is a moving target. Nobody knows the answer to that. And one of the problems is as soon as a number is announced, it's incorrect because people out there say, there's a lot of jobs, and then they decide to come to nursing programs. Or they hear that new graduates are having difficulty getting jobs, and then they don't come to programs. But Peter Bierhaus, I think, probably does the best estimates of these numbers, and he anticipates that by 2025, we'll need about 250,000 more registered nurses, and at the rate we're producing registered nurses, we will not be able to achieve that need. What else is going on in the environment? You all know about the Affordable Care Act. That we anticipate is going to dramatically increase the need for nurses, both advanced practice nurses and registered nurses, because many people who didn't have coverage for preventive services will now have coverage. And you may not know that people on Medicare have not been able to get reimbursed for preventive care services. So often what happens is you go to the doctor for a checkup, or my mother goes and she's got hypertension, so they check hypertension and she gets reimbursed. But for people who don't have diagnoses that can be reimbursed, that's particularly problematic, and that will change. What's going on for the IOM report? The focus of the IOM report is not about nursing. The focus of the IOM report is about improving healthcare quality for people in the United States and improving value. And one of the things that the report points out is how important nurses are in achieving that goal. The committee had only 4 nurses on it. It was a multidisciplinary committee with many leaders. And what's, I think, important about the report is this wasn't a nursing report about nursing, although there's nursing in the title. It was really a report from a very prestigious group by non-nurses about how vital nurses are to the future of healthcare in our country. And that's this slide, so I'll keep going on. I just want to highlight 4 of the recommendations. There are 8 recommendations. They're on the back of your program, so I won't go through them again. My understanding of the report, and I'll be interested in what you think, is that these recommendations were in order of importance. And the first was that advanced practice nurses must be able to practice to the full extent of their education and training. And I think Mark will talk a little bit about that. I think Mark is next, but I can't remember, but he'll talk a little bit more about that. Recommendation 4 is that academic nurse leaders should partner with education, accrediting bodies, and private employers to get the percentage of nurses with baccalaureate degrees to 80%. You saw on my earlier slide that right now it's about 50%. This is going to be a major challenge, how we do that. It is not going to occur by everybody going to baccalaureate programs. I think that the writers of the report hope that it will occur by associate degree graduates going on for their bachelor's and for people to go directly into baccalaureate programs. Double the number of nurses with doctorates by 2020. This is my favorite one because I work at New York University and I think it's really important. But if we don't have enough nurses with doctorates, we won't be able to educate the next generation, and we won't be able to produce the science that we need to improve the quality and value of healthcare in this country. So I see this as critical. And finally, to build an infrastructure to analyze and collect healthcare workforce data. It's kind of sad that New York only got a nursing workforce center 2 years ago, when many, many other states had such centers. And we need to get some infrastructure funding for these kind of institutes at the state level, because that's where most of the data are. And people need data in order to make decisions. Kim needs data to know what's going to happen about new graduates, and Mark needs data so when he's trying to figure out how he's going to staff the primary care groups, and we just don't have it, and particularly we don't have it in New York. Part of what's happening in terms of implementing this report is the Johnson Foundation has developed regional action coalitions. They picked 5 states to pilot and sent emails to people who are somehow involved in the foundation to ask them to lead these 5 states. New York was picked as one of those, and a group of us have started working on that. It's being handled out of the state nursing workforce center, but we really are trying to get everybody involved. And people can be involved in a whole variety of ways. Here's some information. You can talk. I think one of the things that we can all do that we forget about is we all know people in our regular life. You know, our father is an executive at Xerox. Our cousins, whatever, works for the telephone company. Those are all connections to people to try to get people from all walks of life involved in and wanting to improve the value that we get for healthcare and improve the quality of healthcare for people in this country. So when you leave here tonight, you don't have to sign up for anything. Just talk to your family members. Talk to your friends who are majoring in other areas at NYU or at Penn. And that's the first way to start. And then if you want to get more involved, you can go to this website. And here's the information for New York. It's not a very catchy name. And so I was a little unhappy with that, and we didn't think it through very well. So there's no, I don't know what the acronym stands for, but you can, I'm not going to remember it, so I have to put it up there. And you can send an email to that group saying that you want to work. You can work on a particular recommendation. There are committees that are formed now to work on the areas, or you can work regionally. So we're going to have groups working in 5 or I think 6 regions of the state. I hope you'll be involved. I hope you enjoy the rest of tonight. If you have any questions for me in particular, my email is christine.kovner@nyu.edu, and I'm happy to answer questions or connect you with people who can provide some information to you. Thank you. Oh, we have questions. Okay. Did I take too long?
Actually, you don't have to wait to send an email. You can ask her right now. Here she is. So, questions for Dr. Kovner on her presentation, any aspects of it?
It's also fine to save your questions till the end. Yes. Okay, so I'm trying to figure out the question and all that. And so you could remind me if I've forgotten something. So the first question, I guess, is why did the committee recommend this? The way the Institute of Medicine works is every single recommendation has to be supported by evidence. And the committee looked at the evidence and thought that we would be more likely to get good value and to have high quality care if we had more nurses prepared at the baccalaureate level. One of the things that happens with the report is the committee drafts the report with help, and then the report has to go out for outside review. And Christine Gebbe at Hunter College, College of Nursing, was responsible for that part of the project. The report went out to 16 people. 16 people made comments and questioned the recommendation. I mean, this is what I hear, because I wasn't allowed in any of the meetings. The committee had to respond to every criticism. Now, they could say our data suggests different than the commenter did, but they have to provide evidence or the report can't go out with the stamp of approval of the IOM. The committee reviewed the evidence on healthcare and believes that while associate degree nurses are vital to providing healthcare in this country, our system would work better and our costs would be lower if we had more people prepared at the baccalaureate level. So that's number one. Number two, I thought you suggested that baccalaureate graduates don't get as much clinical as associate degree grads get. I mean,
They get as much.
yes, they do.
I don't know, I think there's a little bit of distance because you're taking the same board. You have, that's the great equalizer, is there's a board that is taken and it's the same class.
Yeah, and I think one of the issues in healthcare is that we have to have some kind of metric to decide who is able to practice and who the government gives permission to, and so that we can maintain the safety of people who want to enter the healthcare system. I think we all recognize with all of these kinds of tests that they can't test everything. I think we're getting better at it. We at NYU are using simulation more. And I think the answer is the NCLEX exam is a basic exam. And it doesn't assess in any reasonable way lots of other kinds of skills that people have who graduate from different programs. Anyway, I think we should go on to the next speaker.
Let's take one more question, and we need to move on to, if there's another question, we can take that at this point. Okay, well, there will be time afterwards where you can speak with Dr. Fulmer, because we will have a reception as undergrad, and then the opportunity to speak one-on-one. Thank you.
Thank you. And, you know, please do continue to ask questions. I mean, this is meant to spark a debate. There's nothing in here that isn't worth discussing, that isn't worth, you know, taking to the level of saying, let's talk about it. That's, you know, what we're really trying to do with tonight is bring it out on the forefront. We as Hillmans are, you know, actually a good representation of the nursing profession. We have associate degree nurses, we have bachelor's degree nurses, master's degree, and we have PhD prepared nurses, all Hillman scholars, all connected through nursing, which is sort of, you know, symbolic of what's also out there. So these are things we, not only amongst Hillmans, but even in the nursing profession altogether need to be talking about. So, you know, I encourage you to continue to ask, even if it, you know, feels like a racy issue. Next, we'll be hearing from Dr. Fairman, so come on up.
Good evening, everybody. I was not one of the committee members. However, I was the next best thing. I was staff to the committee, which meant that I got to be in those secret meetings, and I got to do some of the research and write and edit, and was in the process almost from the beginning to the very, very end. And so I do know some secrets, but they are secrets. And part of part of, for you who have been on the committee, you know part of that process is the confidentiality agreement. However, I'd be happy to answer some questions afterwards that I can. Now, I am a nurse historian, and historians are interested in change over time. So what happened when I was part of this process is people would say to me, geez, I hope this isn't the same old, same old. You know, that this committee comes out with really energetic, all kinds of really wonderful recommendations. And so what I did was I went back to the 1983 report and I looked through the archives at the Institute of Medicine and sort of got a sense of maybe how things were different and sometimes how things were complementary and somewhat similar. But I think the reason to ask this question, why the 1983 report, which is the last time the IOM did a gigantic report on nursing, why is it different? Why is this 2010 report different? How is it different? And why is it so extraordinary? And I think it's important to ask those questions because I think it's important to energize the profession and the stakeholders to move these recommendations forward. If we're not energized about them, they will sit. But what I'd like to do is tell you a little bit about the context for 1983, their recommendations, what came out of that report, and then sort of bring it back to 2010 and tell you a little bit about why and how it is different. Now, we know that nursing is a frequently studied profession. So since 1918, out of my own time frame here, since 1923 in the Goldmark report, which was funded by the Rockefeller Foundation, there have been numerous studies about nursing and nursing education. They examined the diversity, the clinical practice boundaries, workforce capacity, and relationship to the public that it serves. The IOM itself, since 1997, has had over 20 studies that focused on nursing, or task forces that studied nursing. Nursing, as we know, is a really vital social service, but it has been troubled, and it's been troubled for the last 70 years. So that's been one of the reasons that all these studies are done. Everybody's trying to get a handle on how many nurses we need, you know, how do we change diversity, how we do all these kinds of things. But the reason I think it's also interesting for people to study is that nursing has an essential, indispensable relationship to the care of the sick and the support of the well. But the repetitions of the studies and their recommendations, I think, are also indicative of the exclusion of nurses as part of this process. The failure of the profession itself, either through lack of resources or lack of political will, to follow through with the study recommendations, or the failure to redirect the focus of these reports onto patient care from the profession. Most of the studies up until this point were, in a sense, a way to legitimize what was going on in nursing, not as a way to transform patient care, which is part of the charge that was given to the Institute of Medicine for this last current study. So there are three things to remember about any study that gets done any place. The first one is that every one of these reports comes out of its particular context and its social and political context, which may have little obvious connection to the subject that it studies, but a great deal of connection to the people on the committee who have particular interests. So all of these reports, no matter which one you look at, they're inherently political. Number two, there are some continuities in these reports. For example, they both study race, class, gender, economics, and workforce. These are key issues. But the third point is that it's not the same time and place. Race is different, gender is different, workforce is different. So all of these things blend into how the 1983 report is different than this one. So what was happening in 1983? Just to give you a sense of the context, and this may seem rather familiar to you, but the country was in a recession. After the Carter years came the Reagan conservative Republican agenda. This had to do with getting the federal government out of funding certain programs and decreasing the size of the federal government. So we've been following this new freshman class in Congress. What's their aim? Decrease the budget, right? Get the feds out of funding certain programs and decrease the size of the government. Well, the same thing was happening in '83. There is a primary care shortage. There is little funding for chronically ill. Almost every single penny went into funding acute care and acute care hospitals. Hospital costs were skyrocketing particularly Medicare. So we have states like New Jersey who are starting some really innovative programs that would then be the seeds for the prospective payment system and DRGs. So remember, the report comes out in '83 and DRGs get implemented in, I believe, '85. Don't ask historians dates, we don't know them. But I think it was about '85. So everything that committee did for the '83 report was out of sync by the time the report came out, because the whole healthcare system and the funding system changed, okay? So there were proclamations of a nursing shortage, and this was a World War II phenomenon. There's no sense of nursing shortage until after World War II. Remember, most hospitals were staffed by students, which you probably would say today is true or not true, but you know what you do. But after that, hospitals were staffed primarily by nurses, okay? And there were not enough nurses. There was a big numbers problem, but the problem is nobody knew how many we needed. It's a new thing, so it's a big staffing problem. Baccalaureate education was in flux, okay? These programs are really hard to grow, and after 1979, the Nurse Training Act stopped doing capitated funding for baccalaureate programs. It funded their equipment, it funded their schools, it funded the students. And the focus on funding was on advanced practice. Didn't call it advanced practice, but it was expanded practice and specialty practice. There's the problem in negotiating the difference between baccalaureate programs and associate degree programs. And that's one of the reasons that associate degree students at that time were being funneled into long-term care, where their skills and their competencies met with a patient population that was fairly stable. So we see a lot of things changing about education. Nursing education was funded through the Nurse Training Act since 1964, $1.6 billion from 1964 to 1984, when the next Training Act came up, where $1.6 billion was funneled into nursing. And by 1979, most of that was going into advanced practice. Now, the 1983 report was mandated by Congress through the 1979 amendments to the Nurse Training Act. It was mandated because the last 3 presidents had tried to get rid of the Division of Nursing. Now, most of the money for nursing education came through the Division of Nursing. These presidents tried to get rid of the division and tried to get rid of funding. So finally, they had a Republican Congress, a Republican president coming in, and they were able to get Congress to ask the Institute of Medicine, do we need to continue funding nursing education? So there's the politics of all this. And we always seem to think that everything happens because it's really good and generous and nice, right? Everything is politics. So the very first charge was should we still fund nursing education? And the second was to figure out how to get more nurses to work in underserved areas. And the third one was, which was interesting, was that they wanted to encourage nurses to remain active in their profession. Now, in 1980s, the 1979s, 1980s, 75% of nurses, most of them women, worked in the profession. So this part of the charge was really very old-fashioned and really spoke to their sense of what nurses did. You know, they got married, they moved out of the profession. You know, it was a very old-fashioned sense, and that's why this charge is in here. So that reflected a lot of gender concerns and class concerns. The very first recommendation of this report in '83 was to cut out funding for nursing education. So they were able, the committee came forward, cut out all funding for nursing education except for expanded practice, nursing specialists, and faculty. So remember, there's a shortage of faculty during this time also, which sounds very familiar. The committee decided there is no aggregate of shortage of bedside nurses. And remember, this is pre-DRG, so the DRGs come in and change the whole scenario. And they made hospitals very dependent on nurses who had the competencies to move patients faster through the system. So by '88, there's a total nursing shortage because we need more nurses to move people faster through hospitals and out faster. So again, the report itself was, in a sense, out of date by the time it was put out. The second was that they wanted to send all the funding responsibility back to the states. Well, the states had no money. Right? Just like today, you know, we have some states who are looking at, they're almost bankrupt. They didn't really seem to care about that. They thought the states needed to do this. no real outcome or implementation strategy associated with the 83 report. And it took almost 5 years for any group to take up the cause to move forward on the recommendations. The biggest one that came out of the report was the development of an institute within the NIH to study preventive health. See, here's the original charge for the National Institute of Nursing Research. Study preventive health measures, impact the quality of nursing care on patient outcomes, and look at how nursing can cut the costs of patient care. This first was called the National Center for Nursing Research, founded in '86. It became the National Institute for Nursing Research in '93. The other thing that came out of this report was a recommendation that funding programs only lead to master's and PhD programs. So no longer were baccalaureate programs going to be funded, no longer were nurse practitioner programs that were certificates that were done in doctors' offices and public health centers, no longer would be funded. All the funding was going to flow to master's and PhD programs. So you can see sort of how we got to where we are in terms of requiring master's degrees and DNPs eventually, in terms of nurse practitioners. Now in 2010, what do we have? We have rising healthcare costs. We have growing support for changing fee-for-service to new models of care like accountable care organizations and medical homes. 30 million uninsured Americans. Economic problems, wars, mortgage problems, you name it. We've got it. Joblessness, ballooning deficit, shortage of primary care providers, nursing shortage, faculty shortage, all done in the context of health reform deliberations. Same thing. Increasing focus on public health and primary care. This is where most people will be cared for in the future. That's where some of these recommendations come from. And then the RWJ approaches the IOM, a unique partnership between an outside funder and the Institute of Medicine to look at how nursing can transform the healthcare system. Charges reflect this. They reflect the interests that the RWJ had and that the Institute of Medicine had, really, within the context of health reform. So contrast, at first glance, the 2010 recommendations, which are on the back of your program, seem to mirror the 1983 recommendations. There's some continuities, but there's some real big differences. And the differences, the 2010 report is more focused on the patient than it is on the profession. It's very outward-looking and sees nursing as part of a larger workforce to transform the healthcare system. There's an implementation program. RWJ has worked with stakeholders to put an enormous amount of money into moving these recommendations forward. Very few reports that come out of the Institute of Medicine have that backing and that stakeholder commitment. And speaking of stakeholders, it's a partnership with the largest consumer group out there, AARP, to partner to push these recommendations forward. It's a difference. For example, the idea of removing barriers to the scope of practice. 1983 report was about getting the foot in the door for nurse practitioners and nurse midwives and nurse anesthetists. The 2010 report is seeing these types of advanced practitioners as part of the healthcare system, as part of the growing solution to improving healthcare to the American public. The recommendation 80% by 2020, 83 report made no mention in terms of no stand on entry level into nursing. You can see from the discussions there's push to go all baccalaureate. Doesn't happen. They don't have the evidence and they don't have the willpower to do it. In 2010, we're looking at the need for developing consistent competencies which is based on education and skill level to improve care not only in hospitals but in the public's health and in the community centers and in those settings. Nurses with those skills and competencies to do that. Leadership's mentioned in '83, but it was in terms of clinical, being part of decision making. In 2010, it's broader. It's looking at all aspects of the healthcare system. The commonalities are that the reports were generated during disasters and economic upheaval. You can see the contrast between the two. There was some urgency here. They served a political purpose. So we have the Republican agenda, conservative agenda, decreasing the government size in '83. And in 2010, we have healthcare reform in the context of healthcare reform. The similarities, as they are, they're superficial, but there are some similarities, as I said before, and there are some differences. So in the end, the 2010 report is different, I think. And over time, it's for our time. It's for our place. It's for the next 10 years for us to transform nursing and moving it forward to be part of the leadership that transforms healthcare. Okay? How we get there is going to depend on all of us. We're not going to take up each little recommendation altogether. We're going to figure out where we can target and where we can help. It will take all of us, though. Thanks.
Thank you, Dr. Fairman. That was wonderful. Bringing the past and the future together is always an important thing in moving forward. I think I'm going to, if you're okay with this, hold off questions maybe till the end for the sake of time, because, we want to give you all a chance to mix and mingle. So, Tyler, do you want to call up Dr. Gore?
So now I pop up to tell you that it's my pleasure to introduce Dr. Mark Gorvich. As I said before, he's a practitioner in internal medicine and primary care, and he is going to reflect on these recommendations and findings from his perspective. Dr. Gorvich.
Let me just find my slides quickly. There. Yes, yes. All right. So, good evening, and thanks to the College of Nursing and to the Hillman Foundation for this opportunity. It's really very special. So, and it's not something that I am accustomed to talking about. So we'll see how that goes. Basically, you've already seen the 8 recommendations. I'm going to focus on a couple only, on removing the scope of practice barriers, on the issue of increasing the proportion of nurses with BAs or bachelors, on the issue of nurse residency programs, which is part of the training recommendations, and on thinking a little bit about the data infrastructure that might be helpful going forward. So the scope of practice expansion, we've talked about this a little bit, and I want to try to put it into a little bit of context. So the issue here is that there is tremendous state-to-state variation in advanced practice nursing privileges, and so in practice. And so you see as you'll see in the next slide, and this comes in terms of physician supervision and collaboration, prescribing, ordering and evaluating tests, and hospital admitting privileges. And if you take a look at this slide here, you'll see in purple the states in which there are no restrictions. There are 16 of those states if you include if you include DC. And then in blue are the most sort of restrictive states, which are obviously the majority, in which some kind of collaborative agreement is required by law to diagnose, treat, and prescribe. And then the other colors are sort of various variations on that in between. So, if you take the big picture and you say, look, what are the data to suggest one or the other, it's hard to conceive of any framework that would make for state-to-state variation. This makes a lot of sense to do this in Colorado, but Kansas, forget about it. How are we going to account for that? So it makes no sense. And I think that's, the question is, what should it be? But it should, that it should be uniform, it seems very plausible to me. And the IOM report said, yes, it should be uniform, and yes, it should be unrestrictive. So that's great, but let's think about the context here. So there's, in 2011, in healthcare, we have a lot of, it's tremendous, it's evolving incredibly quickly. So for those of you who are in training, it is actually one always says, oh, it's a very exciting time to be entering the profession. But in fact, it's a very exciting time to be entering the profession because the whole thing is actually getting rethunk. And that's unusual to come in at a time when that's happening. So team-based care, which is something that we've all been talking about for a long time, is actually being built into reimbursement systems. So the patient-centered medical home, which is the PCMH, you'll hear about that, it's sort of an old wine in new bottles. It's primary care, but where it's structuring the care delivery system in such a way that there is continuity of care, that people's health information is in one place, that it's patient-centered, and that is team-based. And so reimbursement is going to be tied to that. In fact, already is tied to that. So there are mechanisms now in place that put teeth into some of these concepts that in the past we've embraced, but not as forcefully. Transitions of care, team leadership. The primary care workforce, as we've heard, is inadequate to the task. So what are the data on advanced practice nurse outcomes? And the data actually are encouraging. The data suggests that there aren't a lot of studies, but there are some studies, and there's some good studies, including ones that have been done here in New York City. And they suggest that if you look over the course of about 6 to 12 months, that patients with asthma, diabetes, and other important outpatient, chronic conditions rather, have similar outcomes at 12 months down the road, whether they're managed by an MD internist or by an advanced practice nurse. So that's good. But the question is, what else do we need to learn about that in terms of future research, duration of follow-up, acuity, and therefore, how does one set this up best to work? So I want to talk a little bit about this. If we have more, if we get rid of the restrictions, which I am a proponent of, I endorse that certainly across the country. But that seems like an easy question. The harder question is, how do you set up the practice world such that advanced practice nurses are doing what they do best, and that there's a appropriate mix of skills in a team or across teams. So the question is sort of then who actually ends up caring for whom? Are there complexity-based criteria in terms of, let's say, advanced practice and physician roles? Are they really just simply interchangeable? I don't think they're interchangeable, but I think for some things they're interchangeable, and for other things they're less interchangeable. There are surely some things that advanced practice nurses do better than physicians. So the question is, like, how do we optimize this? How do we match the clinician's depth of training and experience with the patient? What about continuity of care? What if the complexity changes over time? How do we manage those transitions and handoffs? Are the handoffs in both directions? And do we think of this differently in rural where there's or healthcare shortage areas as opposed to in other areas? There are a myriad number of issues that will have to be, I think, tackled, for which there aren't really guidelines or accepted guidance really on how to actually do this. I think there should probably also be transparency with respect to the degree that the clinician has, just so from a patient-centered point of view. So that's a little bit about the scope of practice issue. On the training issue, we've already heard some about it, so I won't say very much about it, only that the goal of training, that 80% of RNs have bachelor's degree by 2020, as Chris acknowledged, it's a steep goal. 2020 is almost here. And that's from 50%, which it currently is, to 80%, that's a 3/5, 60% increase. Is another way to look at it. It's a gigantic change. So achieving that seems like a real reach. Sometimes one sets reach goals, in the hopes of getting halfway there, or even in the hopes of really getting there. But it's a reach goal. And the one concern is if you increase the proportion of RNs with bachelor's degrees, and to the question that was asked earlier, also one of the other reasons that the IOM gave is that would help increase the supply of nurses who could then go on to advanced practice degrees. But then will you risk depleting the ranks of the generalist nurses? And this is a slide from the report that shows that in blue that 60% of RNs are employed in hospital settings, right? So if more nurses go on to advanced practice degrees, are they as likely to practice in hospital settings or other settings? And we need those nurses. So that's a question. Another issue that the report raises that is complicated, I think, is residency training for advanced practice nurses. So physicians, as you know, go through a formal residency training, and to figure out A. B, there's probably, there's an intense tussle all the time within medical training for the graduate medical education dollars that fund medical education training. So if one were to open up to a whole other field, the need for residency training, that might make for a competition for those dollars. It might not. Maybe there'd just be more money. But, you know, that's not likely, actually, right now. Or maybe some more money, but not enough more money. And so how do you make that decision? Should we have fewer specialists? Well, we're expecting 30 million more people coming into the healthcare system at least regularly soon. So, you know, I'm the first one as a general internist to say, oh, let's just cut the specialists back. But it's complicated. And certainly we need to think also here, this is the same slide again, there's two slices. I'll show you the other slice that I think is interesting. On the top left is the light orange slide. Those are the 10% of nurses, of RNs now we're focusing on, are in ambulatory care settings. So is that the right proportion? And if we train in residency, I mean, that seems low to me. Or rather, it seems that in expanding primary care, we're going to need to expand that slice as well. So how to mesh that with the need, with the thinking about residency training is I think, very important. So second to last slide, just to say that, the final recommendation, and I hadn't realized that the recommendations were in the order of importance. From my mind, if the 8th recommendation is that we need some more data, I would have put that up a little bit higher. The question is, what actually works best? And we just don't know, I think. There's a tremendous amount, and so there's an opportunity here to really learn and ask questions in patient panels. Should they be complexity or acuity adjusted? We need long-term follow-up looking at outcomes, patient outcomes, according to different care delivery models, in terms of health, patient satisfaction, costs, and so forth. Many of these are issues that we've already touched on. And so moving forward, I would really just say that if you look at what we've got here in this country, right now, the population impact of preventive and chronic disease management care is already subpar, right? We're not doing a great job of translating healthcare delivery into improved population health, public health, the health of the population. We do, like a B- job. And so if you take that, and then you think that we're going to add 32 more million people through the Affordable Care Act into fully into care, they're already touching the healthcare system, right? That's a big challenge. So if you take an okay system and then you give a huge influx, so how are we going to tackle that? So we need all hands on deck, right? So there's not a big argument that we need more active clinicians in this, but, and so to do that, I think we'll need to foster these diverse, innovative care delivery models, and really to think of delivery systems sort of as learning machines, right? Because we're going to need to do a lot of innovation. We need to try this model here and that model there and this model here, and then analyze it and study it and apply, sort of compare the effectiveness of alternate models. And I think if we do that, we can hopefully realize the promise of patient-centered care, of the medical home, and of team-based care. That's the goal. So thanks.
We're going to keep moving, but we certainly do appreciate that very thoughtful presentation and raising so many complex but challenging issues for us to consider. So thank you so much. It's very enlightening. And I think taking Linda's lead, we'll just keep moving. Linda?
Just go ahead.
Okay. So we can get back to questions later.
That's right. So I'm a chief nurse. I can just stand up and do this. And students always go last. Very powerful position. So I was asked to talk a little bit about the perspective of a chief nurse in an academic medical center. And why would that be important? Well, I think that there's a relevant perspective here because being academic medical center born and bred, I live in a very physician-centric culture. So if you think about what an academic medical center is, in the definition that I use, it's often a campus that is shared by a hospital and a school of medicine. So the job of the School of Medicine is to educate physicians, which gives it its physician-centric culture. That said, nurses outnumber physicians 4-to-1 in this country, and we clearly outnumber them 4-to-1 in an academic medical center. And as I am fond of saying, nobody gets to a patient in a hospital without going through a nurse. So why is it that the conversations around these recommendations are sometimes difficult? So my job as a chief nurse in an AMC is to help educate and influence my physician colleagues about how nurses can help. So what is the role that we play in the delivery of health care in collaboration with physicians, but that's different from what physicians do? And how do we begin to shape our voice around those issues? One of the sad truths, I think, so there's good news and bad news about this, is at this point in time, academic medical centers are very focused on payment reform. So the bad news is the Future of Nursing report is not foremost in people's minds. It's not foremost in people's minds because this is about money. And when I look at my colleagues in New York State, particularly those in public institutions, everybody is totally focused and freaked out about what's going to happen with state Medicaid funding. And I would bet that we're not the only state that's worried about this. So my chief nurse colleagues around the city, particularly those in public hospitals, are sort of gearing up to sharpen their pencils for what is this going to mean for the public sector in terms of a huge bolus of funds that they rely on to fund their workforce and to fund care that they're anticipating is going to be a problem. So we're very focused on money right now, which means that having discussions about the role of nursing is something that you have to weasel your way into. So how do we do that? Well, next week, actually, the academic medical center chief nurses are meeting to begin to discuss our strategy for how we're going to help implement these recommendations. So one of the great things about AMCs is I have wonderful colleagues like Mark to work with. So we innovate. We have an infrastructure to innovate. We have a research infrastructure. And in private, nonprofit academic medical centers, we have resources. So if there are going to be care innovations and tests of change of these IOM recommendations, I think that the AMC is the likely laboratory to have that happen. So as we sit down as a group next week to have these conversations, there's a couple of things that we're focusing on. So the recommendation about full scope of practice for APRNs is clearly important for all of the reasons that were noted. But in having this discussion in an AMC environment, the one thing I stay away from is the issue of competition. So this isn't about putting physicians out of business. It's about having a conversation, as Mark said, about how you structure the team. So nurses and doctors have complementary but fundamentally different practice. Physicians diagnose and treat disease, so they're very focused on what's wrong with you. I go to physicians, we all go to physicians. Nurses come at patients from a different side of the looking glass, so I like to say we're the existentialists of healthcare. So we're pathology neutral in many ways, and we're looking more broadly at a person and what it is about this condition that a physician has diagnosed. What is it about this condition and this treatment that's been prescribed that we're going to help them live with? So Mark and I, in our collaborative practice, he's going to prescribe a set of medications and treatments for a physician, but I'm the one that's going to help that patient figure out how to live with it. So when you structure this collaborative practice you have a relief and an ease of tension that allows everyone to have their space around the patient without this hysteria that I think accompanied part of the release of the IOM report from selected medical societies that immediately jumped on the bandwagon that this was going to not solve the problem. So it isn't about that. It's about what space does each occupy, what do we do that's complementary, what can I do to relieve Mark of his burden so he can focus on some other things, because there aren't enough people to go around. So fighting about who's going to own what piece of turf is only going to divert us from the problem of how to take care of all these people in the future. I would also add that the full scope of practice piece shouldn't just be about advanced practice nurses, it should be about registered nurses, because there is a lot that registered nurses can do to contribute to the health of this nation today without any change in opening up a state practice act. And given how this recommendation is phrased, it is going to be a bear to open up state practice acts in 50 states in this country. But clearly, this is going to be a partnership of nurses from all sectors to be able to lobby our state legislators to make sure that they understand that this is important, and we're going to need our physician colleagues and our public colleagues, our funders, all kinds of people to help join us here. We can't do this alone. I think that the recommendation about leadership and collaboration is well demonstrated in many academic medical centers, so I'm at the table. I don't have to fight my way to the top. I'm part of a senior executive team. I have lots of opportunities to talk about how nurses can help, how do we support and influence quality and safety in hospitals. Everybody gets that. So I think that there's some good conversations that can have there. And clearly, we are a magnet hospital. HUP is a magnet hospital for those of you from Penn who practice in that setting. So we have some great collaborative programs in both of our hospitals, I think, that already bring these IOM reports forward. So that's part of the evidence that underpinned what went into this report. Nurse residency programs, both HUP and NYU have had one for many, many, many years. We designed it as part of a group of AMCs. It's well researched, it's well established. And our next step in this evolution of nurse residency programs, which we self-fund, is to now get them accredited through the same organization that accredits university nursing programs. So it's why our nurse residency programs were done in partnership with our universities so that we could use the Commission on Collegiate Nursing Education as the accrediting body for our nurse residency programs. And this is the first step to trying to get them funded. So there will be a competition for funding, but I think that when you look at the practice of baccalaureate degree nurses, which we have made a commitment to in our hospital, we have a 92% BSN rate, over 92%. We only hire new graduates with bachelor's degrees. We do hire nurses with associate's degrees. I don't know where our friend went. But we do try to assist people to get into a BSN program because we feel that's important. Healthcare is complicated these days. It needs a lot of critical thinking. So this transition into practice, the same way it has been mandated for physicians, recognizing that their first year out of medical school is a critical transitional year, it's the same for registered nurses. I think that I had one more comment. So there's a number of components of these recommendations about supporting education and lifelong learning, helping people to lead. So that is enabled by hospitals having tuition assistance programs, support for continuing education. New York State does not have a continuing education requirement for nurses to get licensed. Our hospital does. So you begin to make these changes one facility at a time, one day at a time, have conversations, have meetings such as this so that we can get these talks going and figure out how we're all going to approach this. Thanks.
Thank you, Dr. Glassman. That was extremely enlightening. If I can take an opportunity to call the panelists back up to their chairs, and maybe we'll open up for questions to anyone who has anything. Sure. Hold on. I'm going to call up Aaron first. Go ahead.
Thank you so much. Just a great panel. I have a number of questions, but I'll just keep it to one. I was curious about Professor Gorvich, the slide that came up that was detailing the workforce in 2010. This is kind of directed to everyone, but I think especially the two of you. I'm interested in the projections for what the workforce will look like in another 10 to 15 years. I think as part of some of the IOM meetings, there was a meeting on community health and public health. And I think it's Eileen Sullivan, Marks, and Carol Raphael who gave a presentation about public health and home care nurses, and that the projections for nurses in those particular areas is likely to increase 2-3-fold over the next few years. The numbers might be more than that. And I was curious to know what your sense is of the changing needs of the workforce as we move forward.
Sure. I mean, I think that the need for public health-oriented and community-oriented nurse practice is growing, and it's intense. That's what I think. So, and you know, in terms of reaching people where they actually are, in terms of, and therefore sort of fostering access, in terms of dealing with issues like adherence and behavioral behavior change. You know, 50% of mortality in the United States is attributable to changeable behavior. You know, you can look at it like that cancer and heart disease are the two top killers, or you could also say that behaviors are the top killer. So how do we? What are the skills involved in? So there are our workforce is very, you know, based in the healthcare workforce is so based in these healthcare delivery buildings, and so the opportunity to expand in that area, I think, is the need is intense. I can't speak with any authority about the projections, but I think that part of the push to train to increase the proportion of bachelor's training and then advanced practice nursing is part of that.
I don't know if this is on. I think that the aging of the population is also going to shift this.
Yes.
So those of us who are baby boomers, I'm not going to a nursing home. I want to be at home. So that's where home care is going to come in to try to help people age in place, bring the care to them, and I think that's where we can have these partnerships of these teams to be able to move this forward. But on the point of innovation, you know, one of the quick fixes is that nurse practitioners can't certify patients for home care. So there's some very little things that we could start to tweak that would make a big difference in helping to sort of expand the workforce that can support people at home so the burden isn't just on physicians.
I don't know that anybody has a good number on the predictions, but from when I graduated from Columbia, I've been told that it's really important to do community health, and the numbers are going to go up, and of course they haven't. The number of nurses working in hospitals have consistently gone up over time, and so it's not like fewer nurses are going to work in hospitals. More are, and there's more nurses. Overall, I think the payment system in this country makes it very difficult to figure out what's going to happen. Right now, the best people who get the best money are inpatient institutions like NYU Medical Center. Sloan Kettering probably tops us because they don't even have any kind of DRG system. They just get reimbursed for what they spend. And the system is not incentivized to do that. So in order for the system to change and for us to need, or that there be jobs for, in public health and community health, we have to change the payment system. And when states don't have a lot of money, one of the first things that goes is preventive programs.
Yeah.
Well, I don't know if this is on either, but, okay. The Affordable Care Act was all about primary care and community-based health centers, nurse-managed health centers, public health. So you're right, Chris, I think it's and that was all tied into the payment system. So we don't really know what's going to happen with the Affordable Care Act right now because of the changes that are in Congress. We have a sense of it, but you know, in terms of what will be implemented. But because of that and what we were hearing during those deliberations, there was a sense that the workforce needed in primary care, in community-based care, and in public health was going to have to be increased and expanded. No real projection numbers there, though.
Okay, I saw another hand in the back there. Francie, I think it was you. Yeah.
Sure. Yeah. It's both. Yeah. And it also has to do with changing of place of work. Mm-hmm. So if you work in an acute care hospital and you move to a community-based job, there's the recommendation that you also do a residency in that location also. So, or vice versa. It was based on turnover rates, nurse satisfaction with their job, and some evidence from some data from companies that do run residency programs in terms of outcome satisfaction and patient outcomes and satisfaction, I think.
I think it's also just intuitive that you don't want to subject the public to someone who's come right out of school. Likewise, if you've got a nurse who has been in a hospital all their life, like me, and now I go to work in home care or public health clinic, I need more than a month-long orientation. There's a whole frame of reference that I now have to shift. And I think the discussion about APRNs is critical. So all of you are going to graduate from your baccalaureate program, and your schools that you're graduating from are going to immediately sign you up for your master's program before you leave. And you're going to track into a nurse practitioner program, and that's great because all of these reports say we need more of you. But, and if you're lucky, because you're Hillman scholars, you're all going to get employed somewhere in your institutions because that's part of these connections here. And your institutions in some cases will pay for your education, so you've got this great program going. So you're going to graduate in 3 years as a nurse practitioner, and you've been a registered nurse for 3 years, and a good part of the time you've been going to school. You need a residency program. So we actually are piloting this at NYU to develop what we're calling a fellowship program, modeling it on medicine, so that some period of time, perhaps your first year as a nurse practitioner, is going to mirror your experience as a post-baccalaureate nurse resident so that we can build in that transition, because not only is it a new role, there's a socialization to that role that we're missing right now in our hospitals. I employ over 250 nurse practitioners, and we are working with them on a study to help inform what would be the best program and structure to ease you into that role.
Go ahead.
That so much money is wasted on, we all know
mean, I think the major reason is the way our reimbursement system works. And so, for example, if you're covered by Medicare, Medicare will only provide payment for a few home care visits. That makes no sense. But some of that is in the law, and paying for physician residency programs is another example of something that's in the law. And so to get Congress and the president to have the will to say to the academic medical centers, instead of you guys getting a lot of money, we think we want to give it to primary care people out in the community. And think about the lobby and how important, a state like New York, I think Schumer and Gillibrand are totally supportive of academic medical centers. Now, it doesn't have to be one winner and one loser. We could think about how we can all win at this, but I would blame the reimbursement system.
It just seems like there's a way to do more pilot programs like that and prove that it works. Like, especially at, an academic center where
So
you have the facility, like you were saying, to make that happen.
Those demonstration projects are underway. I mean, they really, there's the Commonwealth Fund is funding them. The Center for Medicaid Innovation is beginning to work with them. Many of us at our various places are beginning to tackle this. So I completely agree with you. We desperately need those data, and there are better models out there, and like the one you described. The only note I'd make is that the idea that they'll all save money isn't necessarily. We think if you just did this better and people took more medication that's prescribed or this or that. Frequently, it costs a fair amount of money to get that care delivered right, and so you end up spending money, and what you really get is better health. So you reduce hospitalizations, but it turns out you've actually spent quite a bit of money on the outside to do that. So it's just people in less friendly audiences will trip you up on that, and it doesn't always save money. It's very, very hard in healthcare to find money-saving prevention measures, but outcome improving, health improving for even the same amount of money, we can definitely do much better there.
I come from community health, and I was arguing for free hospital bills all the time, so I was just looking at how much money, like my patients were all homeless, and I was getting their hospital fees. I know how many thousands and thousands.
Right.
So at the very least, this guy giving him a way to check his insulin, I know what it's, you know what I mean? So I feel like it's not a short-term thing, but it's like a long-term money saver, like in 20 to 50 years. Like that's why it's, I guess, a huge challenge. Anna?
I just wanted to make a comment about that. I'm currently taking a community health nursing clinical at KCCM on 99th between 2nd and 3rd. And they provide comprehensive care management from postpartum until death in all aspects. So it goes from transportation from their homes into the daycare services, into medical care and nurse practitioners that work with them, as well as visiting nurses that come into their homes, I believe, twice a month to take them from being away from the hospital. So their whole process is to keep them as healthy as they can be away from the hospital, and if they still need care into nursing care homes, as well as nurses' aides, they also provide services there. So they follow them through their 55 until death. So there are places that are doing it, not a lot,
Yeah.
but there are places that are
One of the things people said at some of the forums we had was the future is here, it's just not everywhere. So that program sounds a lot like the PACE program that the School of Nursing had. Is it a PACE program? Yeah, so we have a life program, living independently for elders that does exactly the same things. It's run by the School of Nursing. So there are programs like that out there, and I think one of the difficulties is then trying to mesh them together into a coherent system. And that's, in a sense, what what accountable care organizations are supposed to be able to do. It's a payment reform, and it's not going to happen overnight. But if if part of that legislation of the Affordable Care Act actually continues to be part of that act, you know, you will see some changes in terms of how people work together across acute care hospitals to the community and to the visiting nurse associations to provide that kind of comprehensive care. The other thing is that a lot of these demonstration projects are, instead of stopping them after 2 or 3 years, if they show promise after the first year from the Center for Innovation, they are going to be funded, apparently, almost immediately after that, instead of just letting, what happens is they get funded after 3 years, they stop, they never happen again. But we're now seeing some things like the program you talked about and that we have at Penn and are all over the country, really. It's a matter of sort of bringing them together and meshing them within the system. But that's a great, great comment.
Go ahead, Eileen.
Well, not exactly about differentiation of practice, but there is text within the report that talks about valuing nurses across all levels. One of the things that we didn't mention in terms of this 80 by 2020 is that in order to increase the number of nurses we have, we need to get them into programs so they can become the faculty of the future. And in fact, that, in addition to having the competencies to work across settings, were the two most compelling reasons to think about increasing the number of baccalaureates. Understanding that within the system, there's a place for everybody. I mean, obviously, we didn't go for 100% by 2020 for some very important reasons.
All right, I'm getting the nod from Amy and my notes here that we need to be evacuating the immediate premises and enjoy some refreshments outside. If you do have further questions, just hold on. Marilyn, did you want to? Sorry, this is Dr. Marilyn Parker from Beth Israel School of Nursing. Go ahead. One more comment, and then we'll close. So hold on, please. Yes. Yes. Absolutely. Does anyone? Okay, anyone want to comment, or should we end on that note? I think the idea that, you know, and what Dr. Parker started to say was that, you know, it's a stepping stone to something else, you know, trying to get your work experience, possibly getting back into the schools. But ultimately, this is the recommendation. It's definitely something up for discussion, but this is a recommendation that came out from, I'm assuming, a well-researched base. And like Dr. Fairman said, we're talking about 80%, we're not talking about 100. It's the idea that they want to elevate a baseline level of nursing education, moving forward into a very complex health system. So I think that's the idea that we're looking at. And on that note, I just want to say thank you to everyone for coming.